Hello everyone, and welcome to the KISSER International COVID-19 Seminar Series. My name is Bassam Shheba, and I will be your host and moderator throughout the KICS program, where we aim to present and shed light on the pandemic through a global lens. Today's episode will focus on the origin, nature, and rapid spread of Corona, the virus responsible for COVID-19. I have the honor of introducing our invited expert on this topic, Dr. Richard Martinello. Dr. Martinello is an associate professor of medicine and pediatrics at the Yale School of Medicine in Connecticut. His major research interests include the molecular epidemiology and the transmission of respiratory viruses, specifically influenza. In addition, Dr. Martinello studies the epidemiology, impact, and prevention of healthcare associated with infections, including ventilator-associated pneumonia. He is also the medical director of the Infection Prevention Department at Yale New Haven Health. So, without further ado, let's begin this week's episode.
Let me go ahead and I will share my screen and we will get started. Okay, very good. So today I'm going to focus on really providing an overview of COVID-19 with a focus on its epidemiology and the prevention of its transmission, both in public health and in an infection prevention setting. So as we're very aware, we had initially heard about what came to be known as the SARS-CoV-2 virus back at the end of this past calendar year. And in fact, it was on December 31st that China first announced a cluster of lower respiratory tract infections in Wuhan. And things progressed, as we know, very rapidly afterwards. And it was only a few weeks later that here in the United States, we experienced our first case in the state of Washington. Wuhan, I think, for Americans at least, was a city that many of us had not heard of, but came to know a bit as we looked into it. And in the lower left-hand panel, I have a picture of what the city of Wuhan, looks like. And it's actually a city of about 11 million people, and it's actually larger than our own New York City. Of course, since that time, there's been just a real explosion of what's now come to be known as COVID across the globe. Early on, it was declared a pandemic by the WHO. And so far to date, as we can see from this data from Johns Hopkins University, we've had over 20 million cases across the world and nearly 750,000 deaths attributable to this virus. When patients present with COVID, I think something that's very useful to recognize is what that breadth of presentation may be. And I think one of the challenges of COVID has been not only persons who are asymptomatic and who may be potentially contagious, but also from a clinical perspective that patients can present in a variety of different ways. What I show you on this slide is some recent data from the United States Centers for Disease Control and Prevention, where they compared and contrasted the presentation of patients who were not sick enough to be hospitalized and those who were ill enough to be hospitalized here in the United States. And I think what you'll see from this is the overwhelming majority of patients, for those both with mild illness and more severe illness, most often presented with respiratory tract signs and symptoms, such as a cough. And that cough was typically dry, but on occasion was found to be productive. Most of the patients, in fact, did have fever. However, some of them were afebrile. Many of the patients did have other symptoms such as fatigue, headache, and not surprisingly, shortness of breath was much more common in our hospitalized patient population than in those who are not hospitalized. I think one of the real challenges, though, in identifying these patients is that some of our patients present with very mild illness. Some simply with, as you can see here, with a sore throat, with a runny nose. And then, of course, we know that gastrointestinal issues can present with some frequency. In some series, the upwards of 25 to even 50% of patients did have some symptoms reported of nausea, of diarrhea, or abdominal discomfort. While we don't think that risk factors that have come to be associated with COVID are risk factors that lead people more likely to get infected, we do know that these risk factors are associated with more severe disease and a greater likelihood for complications due to COVID. On the left-hand panel, you see a list of different risk factors, and likely the most prominent among those risk factors has been age. We know very well now that for our younger population, while they too can get sick and they too can lead to transmission of COVID, they oftentimes experience more mild illness and are frequently asymptomatic. As people get older, it gets more likely that they have symptomatic infection and oftentimes present with more severe manifestations of COVID disease. Diabetes, hypertension, obesity, and other chronic comorbidities have also been identified as being risk factors for complications due to COVID. Those complications can simply be hospitalization and severe disease. We know here in the United States that our typical hospital experience has been that for those who are sick enough to be hospitalized, between 10 to potentially 20% of those individuals will die during the course of their hospitalization. Oftentimes for those who are sick enough to be hospitalized in an intensive care unit, and for those who are receiving mechanical ventilation, the risk for mortality can be much higher, in the upwards of between 25% and in some earlier series as high as 70%. We do think that over the last several months, the risk for mortality related to COVID severe disease has decreased as our intensivists have become more adept at treating patients and have developed a better understanding of which patients benefit most from mechanical ventilation and how the use of proning patients, so placing them on their stomach while hospitalized rather than on their back, plays a role in a more rapid improvement of the patient. And really the prevention also of the need for mechanical ventilation. Unfortunately, COVID has come to be known to be associated with a number of complications, particularly being seen in those who are most severely impacted. We have seen cases where individuals have developed neurologic complications such as encephalitis and stroke. Oftentimes for our patients who recover and are discharged from the hospital, and even among those who are not sick enough to be hospitalized during the course of their illness, they've experienced a prolonged fatigue during the course of their recovery and a real sense of mental slowness. And it has not been unusual for some of our patients to continue to have these experiences for even months after their acute illness. Oftentimes, shortness of breath accompanies this, and that can be prolonged. And we've seen patients that have experienced continued shortness of breath for weeks or even months. Also, we've seen patients who have a real proclivity to develop thrombosis. And so much of our treatment regimen is focused on trying to precisely anticoagulate those patients. And then, here in Connecticut, we have seen a modest number of our pediatric patients who weren't sick enough with COVID during their initial presentation to come to medical attention, but then subsequently developed multi-system inflammatory syndrome, also known as MIS-C, and have been hospitalized due to that. Among our patients that we've diagnosed with MIS-C, the overwhelming majority have been found to be positive by PCR for COVID or serologically positive. So I wanted to focus a little bit more on the epidemiology, and I think think about what this tells us about the transmission of SARS-CoV-2 and what can be done both from a public health perspective and an infection prevention perspective to really help prevent transmission in those different settings. I think, as we're all familiar with, one of the first major outbreaks that was really witnessed was on a cruise ship known as the Diamond Princess. And this is, of course, a leisure cruise ship that had vacationers aboard, over 3,700 passengers and crew. And in late January, this cruise ship had departed on its cruise. And of course, at that time, COVID was becoming very well known to the world. On February 1st, it departed Hong Kong, and on the 3rd of February, a passenger who had departed Hong Kong on the 1st was identified as being positive for COVID. So once finding that, the ship became quarantined off the shores of Japan. And on February 5th, as an intervention, the Diamond Princess staff required all of the passengers to remain in their cabin. Of course, though, the crew were still involved in maintaining the ship and ensuring that the passengers' needs were met. Of course, ensuring that the passengers had food to eat and other needs were being met. So those crew continued to really be about the ship itself. That period of quarantine lasted for a total of 14 days, and it ended on February 18th. Now, during this time, what you'll recall is that there was a substantial outbreak on that ship. Among those 3,700 passengers and crew, there was over 600 who had become ill, approximately 17 to 20% altogether. What I'm showing you in the figure, though, is what's known as the effective reproductive number. That's represented on the y-axis, and on the x-axis represents time in terms of days. And the figure illustrates by the black line how that effective reproductive number changed over time. And what we look at from a public health and infection prevention perspective is really to see how that effective reproductive number changes. What it reflects is the number of individuals estimated to become infected from one contagious individual. So you could see that by this black line and its surrounding confidence intervals at 1 and 2 standard deviations, shown by the gradation of the intensity of the grayness, you can see that when the outbreak began, there was really an acceleration of that spread among the ship. So as people were interacting more and more, there was a greater amount of spread. And at one point, it was estimated shortly after quarantine began that as many as 11 individuals were becoming sick from one single person who was contagious. What the ship did, though, was to institute quarantine. And then, of course, because of the incubation period of SARS-CoV-2, which has been estimated to typically be around 5 to 6 days, once that public health intervention of quarantine is put into place, it takes some time to see the effect of that action. And so you can see that there is a gap in time between the placement of that intervention, the peak of transmission, and then the subsequent diminishment of the rate of transmission. And while it was thought that placing patients in their cabin was highly effective, of course, there was really twofold reasons why it's thought that spread continued. One, as I'd mentioned, was that the crew continued to interact periodically with patients who were in their cabin to deliver food and other necessities that the passengers had. But also one thing that occurred on the Diamond Princess was that the passengers were contained in the cabins that they were assigned to. And the significance of that is that if one passenger became ill and they had roommates, oftentimes family and friends who were also assigned to the same cabin, those individuals were at very high risk to get sick themselves. And so not surprisingly, the institution of that quarantine, while effective ultimately, it took some time for it to be completely effective, and unfortunately allowed for some continued spread of virus among the passengers and the crew of that ship. So when we think of how pathogens are transmitted, and we think to the experience of the Diamond Princess, we generally think of three different modalities for how pathogens are transmitted. And what I'm showing you here in this figure is a fewfold. One is you see some of the signage from my own institution on when we have concern that a patient may have a pathogen that's transmitted by the airborne route. Some examples of these are tuberculosis, varicella zoster virus, which causes chickenpox, and then, of course, the measles virus. We place patients on droplet precautions for diseases such as influenza and mumps. And then, of course, we use contact precautions for other pathogens such as methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, and other multi-drug-resistant organisms. We do think that the primary route of transmission of SARS-CoV-2 is through the respiratory droplets. And so we really focus on how we use airborne precautions and droplet precautions to prevent the transmission of spread. And in the lower left-hand figure, what you see here is a strobe light picture of an individual who is sneezing. And this picture very nicely illustrates large droplets that we think lead to the transmission of diseases such as mumps and meningococcal meningitis versus the small particle aerosols that transmit airborne diseases such as chickenpox and measles. So you can see this very fine mist in this picture, which would typically be those small particles with droplets less than 5 micrometers in diameter. And these really contrast to those large droplets, which we conventionally think of transmitting things such as influenza and mumps. And of course, these droplets are large enough that gravity has a fairly rapid effect. And typically we think of these droplets as being deposited on surfaces due to gravity within about 2 meters of the individual who is expelling those droplets. Now, of course, this is an oversimplification, and especially as the illustration shows, when people are sneezing and or coughing, we know that those large droplets can actually go much further than 2 meters, and some have estimated even in the upwards of 4, potentially 5 meters away from the individual producing them. This paradigm of dividing up pathogens between airborne, droplet, and contact spread has really been in place for nearly 30 years now. Here in the United States. And it has been a very useful paradigm because with these 3 major divisions, it allows our frontline clinical staff to be able to easily remember what the different types of precautions are and what needs to be done for each of those different precautions. However, I think as our medical and scientific colleagues are coming to very well and better understand, this is really an oversimplification of how pathogens are transmitted. We know that respiratory droplets, if you look at the left-hand panel in this figure, are produced by different parts of our respiratory tract. In this figure, in panel A, you will see particle size on the x-axis, and different parts of our respiratory tract and different aspects of our environment on the y-axis. And so it illustrates that from our upper respiratory tract, most of the droplets that we produce are, while they may be as small as 1 micrometer in size, many of those particles are actually larger. And these are being produced from the level of our larynx and above. But from our lower respiratory tract, we actually normally and continuously are producing small particle aerosols. During tidal breathing, we are producing small particle aerosols. And when we are doing activities such as singing has been brought to our attention over the last several months, and other activities such as talking loudly, for example, we are producing more of these small particle aerosols. And it's thought that these really occur when our bronchioles and our alveoli are opening and closing. So the break in that surface tension is thought to lead to the development of some of these small particle aerosols. And so what is hypothesized is that when a virus such as SARS-CoV-2 or influenza is infecting those lower parts of our respiratory tract, and there's viable virus in those parts, when we are producing these small particle aerosols and we are exhaling, those small particle aerosols then get into the air and potentially infect other people. Now, of course, when any of our respiratory droplets get into the air, we do need to consider that the size of those droplets is not static. It's truly dynamic. And of course, the particle it starts to interact immediately with the environment. So depending on the temperature in the environment, the relative humidity, there may be some dehydration of the size of that particle that leads to even some of those larger droplets to become small particle aerosols that can then are small enough to remain suspended in the air, especially within a room that may not have adequate ventilation for a more prolonged period of time. In the right-hand panel here, you see illustrated how when we are inspiring, where those small particles and those other respiratory droplets that we come in contact with, where do they end up? We know that our upper respiratory tract is quite good at filtering out large droplets from the air. So these larger droplets, illustrated by the dots in this figure, deposit primarily in our upper airways. But those small particle aerosols that can be retained within the atmosphere, particularly in a small room that's not well ventilated for a longer period of time, as we inspire, those particles are small enough to have a better chance of getting to our lower respiratory tract and getting to areas where they can ultimately then lead to infection. So when we think about infectious diseases and their spread from a public health perspective, it's actually very useful to think of it in ways that our mathematical modelers think of. We start off with the public, with patients, with our staff who work within our healthcare settings, who we know are typically susceptible to these pathogens. And of course, there needs to be a way, illustrated by this arrow, that they then become exposed to those potential pathogens. And then there is a probability function that can be used to estimate whether they get infected or not. And of course, some of that may be determined by pre-existing immunity, whether they've been vaccinated for diseases such as the flu or for chickenpox. And if they do get infected, they could then become contagious and be a source of transmission of that pathogen. And that transmission can occur on that spectrum between contact, droplet, and airborne. and is most likely to involve those who are closest to that individual, and it impacts those who are susceptible. So how do we prevent this transmission from occurring? And we really focus on it from a number of different perspectives. One, of course, it's always most helpful to try to eliminate the hazard. And so an example of that would be keeping those who we think are contagious away from those who we believe are susceptible. We focus on environmental engineering, and that could include improving ventilation in our healthcare settings, having negative pressure rooms. And then also, finally, we put a great deal of work into administrative controls. And this could be developing policies for how we use personal protective equipment and how our staff interact with the other individuals. And I'll go through this in much greater detail in a few moments. So I want to focus now on respiratory droplets and really what I think was a very key study that was published in the New England Journal back a number of months ago. And this was experimental work that was done by the National Institutes for Health here in the United States and looked at respiratory droplets that were experimentally produced in the laboratory setting. And they looked at both viruses, SARS-CoV-2, which is, of course, the virus currently causing our COVID pandemic. And they also looked at SARS-1, which, of course, originally presented globally back in the early 2000s. And what they did with these viruses was they both developed in an experimental fashion aerosols containing these viruses, and they looked to see how long those virus particles would remain contagious within those experimentally produced aerosols. And as you can see here over in the top panel, these experimental aerosols that they had produced that contained virus, even in the upwards of 3 hours, and here in red you could see SARS-CoV-2 illustrated, there was still a substantial portion of that virus that remained viable after a 3-hour period. And this is actually very important because, as I had previously mentioned, we know that people routinely produce small particle aerosols. And we know that viruses, when they get into small particle aerosols, some viruses, such as respiratory syncytial virus, is not thought to be very stable in those small particle aerosols. But other viruses, if they are stable, can potentially be then transmitted from one person to the next by those small particle aerosols. And that's in fact what is seen with SARS-CoV-2. And experimentally, it was shown here that virus still in large part remains viable in the upwards of a 3-hour period. What we are still waiting for to find more information on is how those viruses and to what degree can get into small particle aerosols that are being produced by individuals sick with SARS-CoV-2. And that's work that is really currently underway. And we also are waiting to better really understand for those large droplets, how that too plays a role in transmission. But right now, we strongly suspect that those are substantial portions of how this virus is transmitted. The same investigators looked at different surfaces and estimated how long both SARS-1 and SARS-CoV-2 remain viable on different surfaces. And what they had found was that in general, for these surfaces such as copper, cardboard, and stainless steel, and plastic in addition, that the virus would not remain viable for more than approximately 20 minutes for copper, as you could see from this illustration, to about an hour and a half on plastic material. And that was very helpful to see that this virus was not very viable on those different surfaces. Of course, there's still a lot of work underway to better understand when this virus is within organic substances such as respiratory droplets, how long they may last on other surfaces and even on our skin itself. So when we think of public health interventions, and infection prevention interventions to prevent transmission. What I show you in a figure on the left is really our approach to preventing transmission. And so, of course, if possible, we try to eliminate that hazard. And what the elimination of that hazard looks like is what we have done to ask our population to really self-quarantine at home. You know, here in the United States and in many other countries of the world, when the first wave of the pandemic started, there was a great deal of political and also public health direction asking people to stay home. And of course, what's really most important is that for those who are sick, that they stay home, and we think about from an administrative perspective, you know, how we can support people to stay home when they are sick, because those are individuals who no doubt are much more likely to be contagious. And then also, we can try to screen individuals. And so, for example, in the healthcare setting, when individuals, both our staff and our patients, are coming for care in our healthcare setting or to work in our healthcare setting, we can ask them, you know, if they've recently had fever, do they have any symptoms concerning for COVID? And then have they recently been exposed to anybody who have COVID? And we could think about how we modify how those individuals interact with our environment to try to minimize the risk to other people. From an engineering perspective, in our healthcare setting, we oftentimes have negative pressure environments where we can have individuals who are contagious safely contained. At some institutions, there have been attempts to try to improve fresh air intake, and this could be done both through the heating and ventilation system or potentially by simply opening windows. Some areas have found it helpful to add portable HEPA filters to better filter the air within the room. And then, of course, social distancing has been a really critical piece of preventing people from getting sick. And we think about how we could potentially engineer guidance in our environment to guide our people in that environment to better maintain that social distance. We have seen some use of barriers, such as plexiglass barriers, to try to contain respiratory secretions and prevent aerosols from getting into different parts of the room at such high concentrations as they may otherwise do. And then, of course, a focus on environmental cleaning.
Sorry to interrupt, Dr. Martinello.
Yes.
5 minutes, please, if possible.
All right, thank you.
Thank you. Yeah.
From an administrative perspective, we focus on restricting visitors, minimizing occupancy to minimize those who may be sick, and to minimize the risk of those coming in who may come into contact with those who are contagious. Bed management in the healthcare setting is of critical importance to make sure that those who are positive for COVID are separated from those who we are uncertain if they have COVID, and of course, keeping those who we know don't have COVID apart from those who may be contagious so they themselves don't become sick. For hospital personnel, personal protective equipment has been shown to be highly effective, and that includes the use of respirators when we interact with individuals who may be contagious with COVID. And in the United States and elsewhere across the world, we have found that the wide application of face masks has been highly effective. Eye protection continues to be an area of great interest, and we're trying to better define how that plays a role in stopping the transmission of COVID. And then, of course, our routine use of gloves and gowns and hand hygiene are always very important also. There was a recent meta-analysis in Lancet that really illustrated the effectiveness of maintaining that physical distance between people, the use of N95s and face masks, and also the use of eye protection in the prevention of the transmission of highly pathogenic coronaviruses. Much of the data that was reviewed in this study was actually from our experiences with SARS in the early 2000s and with MERS in the early 2010s. And so while it's not clear how entirely generalizable these experiences are to COVID, we do think that it provides us a very good basis and scientific foundation for us to apply these applications. I'm going to skip ahead a few slides, and I wanted to spend a moment talking about the experience in New Zealand. And of course, New Zealand is in a bit of a unique position, for countries around the world. It's an island nation. Geographically, one could consider it to be relatively isolated from other areas. And they were early and very aggressive in their public health interventions. And what I show here is a recent paper that was published in the New England Journal reviewing these public health interventions that were put into place in New Zealand and also their experience. And what you see in the figure on the right-hand side of the slide is an epidemic curve showing the episodes of COVID that were identified within the country. And you can see that they did have a fairly substantial peak, but considering this is a country of many millions of people, the total number of cases that they experienced was quite small relative to other countries in the world. The way they divided up their public health interventions were really based upon actions that were taken at a individual level, so a case-based level. And here they focus quite a bit on contact tracing and ensuring that those who developed symptoms suggestive of COVID were tested and making sure that the appropriate quarantines and isolations were put into place. They also focused on a community level and canceled gatherings and initially closed workplaces. They did, and as an island, focus on border control, and as an island nation, that favored their effectiveness in border control. And they initially put into place quarantines for those who were incoming from other areas of the world, and then subsequently banned actually non-citizens from entering their country. And of course, because each of these different elements of public health interventions can be very disruptive, they also focused on the health and well-being and the economic well-being of their country and put into place various public health measures and public measures rather to support individuals and communities. And you can see that they've been highly successful in controlling the spread of COVID within their country. More recently, they have experienced some additional cases, and they are working on controlling that at this time. So here in the United States, we are oftentimes thinking, about what is next and what are we experiencing. We as a country are experiencing quite a bit of COVID right now. In the bottom left hand, you can see a heat map showing in hotter colors, red colors, where most of the COVID transmission is occurring within the United States. In the upper left-hand panel, you'll see a seroprevalence work that has been done. And unfortunately, for better or for worse, right now within the United States, our seroprevalence remains quite low. And of course, we hope that as our population recovers from infection, so that we will develop, and prior to a vaccine becoming available, that we will develop a degree of immunity as a population that will help be able to slow the spread of COVID. However, only a very small portion of our population has become infected to date. And while that's good news, I think the bad news is that we still have a great deal this pandemic in front of us. And until we have a effective and safe vaccine that's put into place, we can still expect for there to be a great deal of continued risk for spread of COVID within our country and of the United States and also across the globe. We have found from our experiences over the past several months that public health interventions do work. And so we do need to ensure that we empower our public health expertise and focus on our communities, our healthcare facilities, and also on an individual level and family level to make sure that we are putting those appropriate public health measures into place. And it has been shown that the transmission of this virus can be controlled, and in particular through ensuring distance between persons, using respiratory protection, and possibly using eye protection. I'll go ahead and stop there and be very happy to answer any questions and take part in your panel discussion.
Thank you very much, Dr. Martinello, for that excellent and very informative presentation. Before we continue, what I'll do is I will ask first our invited panel of Dr. Badr Al-Anizi, Dr. Ali Al-Hamoud, and Engineer Waleed Roy to kick off the questions. And then, and I invite everybody to unmute yourselves, please. And then once we have gotten any and all questions from them, we can move on to the general participant pool, and they can also participate. Okay, so our panel, anybody have any questions? Yeah, Dr. Badr, go ahead.
Thank you, Dr. Richard. Dr. Richard, early on, we were told about cases of people that do not show any symptoms. And that really was very concerning, because how on earth are we going to quarantine people that do not show symptoms? But now I'm not reading that much about those cases. So what's the verdict? How many people that are contagious that do not show symptoms? Thank you.
So the general estimate at this time, and it does vary a bit between studies, is that in the upwards of 20 to 40% of those who are contagious for COVID may remain asymptomatic throughout the course of their period of contagiousness. And it's important to note that we have also experienced people are contagious before the onset of symptoms for those who are to become symptomatic. And it's estimated that people become symptomatic about 2 to 3 days before the onset of their disease. And in some of the work that we're working on in my own hospital, we found that a modest portion of those who do become symptomatic start to shed virus before they become ill. So in general, about 20 to 40% of individuals contagious are asymptomatic.
Thank you.
Thank you, Dr. Martinello and Dr. Ali. Any questions?
Yes. Thank you, Dr. Richard, and thank you, Dr. Bassam, for inviting me. It's a very informative presentation. Actually, if I can just in 1 or 2 minutes, just describe our current study in Kuwait. And I would ask Dr. Richard if they have done a similar study in their university. Basically, we have done at the Kuwait Institute for Scientific Research in cooperation with Harvard University. We try to determine the airborne transmission, specifically if the virus is carried by small particle aerosols. And we have basically collected the three size fractions, which represent the respiratory system of the human respiratory system. Basically, particles below PM 2.5 to 10, and then PM 10. And we have done this study now for 3 months. And we have put our filters in the ICUs, both negative pressure, normal pressure, systematic patients, asymptomatic, also on nursing stations, changing rooms, and also outdoor of the hospital. And we have, I think we can add some new information and to the World Health Organization. Basically, we have found viral shedding, specifically in different particle aerosols from smaller than 2.5 and up to more than 10, which is droplets. And that we have found it both indoor and outdoor. And so I would like to ask Dr. Richard if they have done any study regarding understanding the aerosol transmission of the virus in their university, and we can share also our results with your studies. Okay.
Yeah, I am aware that there is similar work being done in many other institutions in the United States, including some, with some investigators at Yale University. I think that this is incredibly important work, and I believe what we will find is that, as I tried to communicate in my presentation, is that there is really the transmission of these pathogens are not black and white. There is a lot of, there's really a spectrum, and we may have some individuals who are primarily transmitting by droplet, some individuals who may be super spreaders who are primarily transmitting through these small particle aerosols. And we may find, similar to what was described with SARS back in the early 2000s, that we may see some of these small particle aerosols transmitting at a distance. I think there's many investigators both here at Yale and also at other institutions here in the United States who'd be very interested in discussing our mutual findings and potentially looking forward to and considering possible collaborations.
Thank you.
Thank you. Engineer Walid, would you happen to have any questions?
Yes, thank you, Dr. Richard, for a very informative presentation. It was very interesting. I wanted to ask you about the New Zealand. I enjoyed listening about the New Zealand case, and I was wondering why other countries can't be similar to the New Zealand case. Is it because of the isolation, or how would you recommend that more people tackle, or more countries are towards handling the situation, much like the New Zealand case? Because it seems that in some countries, it's just, we're not really able to control how the spread is being controlled, depending on how we set curfew hours, for instance, here in Kuwait, and sometimes our numbers are exceedingly high, depending on the testing, sometimes it's not, and our government sometimes have different values on restrictions, on airport restrictions. So do you think that the success of the cases that we have there in New Zealand would be like should countries do more like what the New Zealand cases are doing?
Yeah. Well, thank you for the question. And I do think, certain aspects of New Zealand, such as being, relatively isolated island nation, certainly do help. However, I think some things that, where New Zealand was, some lessons learned are twofold. One is the willingness of the leadership of the country to be very focused on those interventions that work. And in New Zealand, their top leadership was very focused on not only listening to the scientists and the public health experts, but also ensuring that their voices, were being heard, communicated, and ensuring that the population understood that they were a priority. And of course, one piece that was so important with this was really the political will. And the country really not only needed to have the political will for their top leadership, but also that frontline willingness among their citizens to adapt to what that new normal became. Now, that said, I think one thing that's very important is, how do we right size this? how do we make sure that while it's easy to shut things down, relatively easy to shut things down, I think it can be much more of a challenge to maintain some degree of operations to ensure that our economies continue, because we do know that our economy is a very important piece that has direct implications on our public health. But again, it really comes back to having that political will, listening to our experts, and ensuring that that political leadership is communicating to the individuals of the country and developing consensus.
As promised, Dr. Ghada, Miss Ghada, how would you like me?
Dr. Ghada.
Dr. Ghada, والنعم فيك, please. Please go ahead.
Thank you. Thank you very much, Mr. Bassam, and thank you, Dr. Richard Martinello, for a very informative lecture. There was one question at the beginning of your lecture that you mentioned complications that could occur to patients. You said pulmonary fibrosis. Other than the neurological complications, there were respiratory complications. You mentioned pulmonary fibrosis. My concern was, would this be a complication that would last for lifelong, like those patients that recover? Would they still have pulmonary fibrosis for long? Do they need CPAP equipments at home later on? Would they be needing, or would it resolve with time? Because lung fibrosis or pulmonary fibrosis is a serious complication, and usually they die of this. So how do they recover after this?
Yeah, those are excellent questions. And I think these are areas that we are still in need of really learning much more about them. And, as we all know, this is we're 5-6 months into really understanding this illness, and we do not have either the amount of time that's elapsed to really understand what the long-term complications and potential resolution or worsening of them are going to be. But also, at least here in the United States, we've been very limited in our understanding of the pathology of this disease, because when we have had patients with severe COVID, we've actually tried to avoid invasive tests such as bronchoscopies and biopsies, that's slowed down our learning about this disease. And likewise, we have actually not performed a great deal of autopsies on patients who have succumbed to COVID. So I think that these are very important things that are going to take a little bit more time, unfortunately, to better understand. And we look forward to seeing it. And I know in my own institution, we've actually developed a special clinic for the care of these patients for the long term, in hopes not only to better understand what's going on, but of course to better care for these individuals.
Thank you very much.
Thank you. Any other questions or comments for Dr. Martinello? Yes, please, Dr. Khais, go ahead.
Yes, hi, Doctor. Thank you for your informative presentation. I'm a physician living in the United States, in New York, and I have two comments. First of all, how would you tell the Kuwaiti population about the New York experience? I believe New York has an excellent experience in terms of controlling the transmission. Second question, to reopen schools. I believe in Kuwait, they're gonna do it mostly online, and in New York, we are doing it face-to-face. So would you say anything regarding school reopening? Thank you.
Yeah, thank you for those questions. And I think regarding the New York experience, as I think those who are listening are aware, New York City was really the first major metropolitan area in the United States to experience a substantial outbreak of COVID. Back in April of this year, and even earlier into March, New York City was truly inundated with COVID, and it had a great and really devastating impact, I think, on healthcare in the city and the patient experience in the city. That said, I think there is a lot of hope that New York City shows us. They took this virus very seriously and implemented public health and infection prevention measures that we had discussed during my talk in a very robust manner. And I think what they showed, and they continue to show today, is that using those public health and those infection prevention interventions, we can really prevent the spread of this virus and minimize how it is being transmitted between people. You know, New York City at this time, despite its size and despite its really high density of people, and even despite their reopening, they're still showing us that this virus can be controlled through these public health interventions. And I think that's a very important lesson for everybody. Regarding opening of schools, so in the United States, we're actually on the cusp of our children going back to school, and so this has been really an enormous part of the day-to-day conversation. What we will be seeing in many places of the United States is either students going back or students studying from home through their computers, and oftentimes what we're calling a hybrid method, where students may be only at school 2, perhaps 3 days out of the week, but spending the rest of the time at home on their computer virtually at school. I think one thing that is really critical to successful reopening of schools and sustaining the reopening of schools, similar to what we discussed about New Zealand, is the leadership and making sure that we have well-defined goals for what we see as a successful school year and why we're doing it. But also, with that leadership, trying to develop consensus among our the staff and teachers who work at the school, among the parents who are working with their children, and the children themselves. And the reason I think that is so important is, we have to realize that any interactions that we're having, anytime that we are getting people together, potentially poses a risk. We do know that through our public health and our infection prevention interventions that we can minimize the spread, but we do know that there is still risk in those situations. And as groups, we have to come to consensus and agree upon what we think are acceptable risks and what we think are unacceptable risks. And we really have to develop consensus where people understand that we are doing everything that we can to try to mitigate that risk to ensure that it stays within that acceptable range of outcomes. And without leadership developing that consensus very quickly, and what I worry about with our schools here in the United States is that if we have anybody who becomes sick, which we will see individuals who become sick, that will degrade into a increasing concern that will lead to the perhaps premature closure of schools. So it's really about how do we have our leadership develop that consensus and develop the successful implementation of these public health and infection prevention interventions, but getting everybody on board so that the children understand that they will be wearing masks, that they will be social distancing, that they're going to be very thoughtful about washing their hands. Parents supporting those changes and making sure that when their children may be sick, that they're getting tested and they're not sending them to school. And our leadership, really working hard to develop that consensus, that understanding, and supporting those changes. That's what's really going to be critical in my mind.
Thank you very much for that answer. I think you hit the nail on the head. A lot of us parents are thinking exactly the same thing. Thank you, Dr. Qais, for the question, because I'd like to take this opportunity to thank Dr. Richard Martinello again for joining us today. It has been an absolute honor. Thank you for kicking off the series as well in style and setting the bar exactly where we wanted it. And we look forward to seeing you all again in our future installments of this series. So again, thank you once again, Dr. Martinello. Thank you to the panel. Thank you to all our participants. And we'll see you all again sooner rather than later, I hope. And this is Sam Sheba signing off. Thank you very much.
Thank you for watching this installment of the Kick series. And remember, you can keep up to date with our webinars by subscribing below. Looking forward to seeing you all again very soon. Stay tuned, stay safe.